All right, Javid, you okay if we go ahead and get started?
Go ahead.
Okay, perfect. So welcome everyone to the start of UCSF's Cardiology Grand Rounds.
Deeper and mechanistic level. This is our group now. It's been 10 months. We have a special group of faculty, Mondar Aras and Alan Beck, who are sort of two people who really, I was convinced this is the place to be. We've had the opportunity to work with Jaya Malidi, who's running a terrific program and is an outstanding physician scientist at San Francisco General. We have two fellows in Amir Munir and Y.C. Chen. We're one of the few places in the country that have cardio-oncology fellowship. And I'll be honest, the real reason we even have a team are the three people listed on the right here: Eileen Gutierrez, Amanda Schnell-Heringer, and Kerry Bradford, who are really make sure we are giving high-level care for all of our patients. So it's really been a pleasure to work with all of you, but specifically with this group in mind. So this is sort of an overview of what cardio-oncology is, and this is how we're at least thinking about our program. This is a figure from a paper I wrote back in 2016, and for the most part, it still holds true about the type of clinical and research programs we're trying to sort of develop. Although, as you see at the end of my talk, we're actually thinking of new areas and new opportunities in this field. And so the idea that cancer and heart disease encounter or intersect is not exactly something new. We knew many years ago that drugs like adriamycin and radiation can cause cardiovascular issues. Although I would argue the field of cardio-oncology goes beyond toxicology, toxic effects of the drugs. For example, we're very interested in how cancer can occur in the heart and how cancer syndromes can cause heart disease. So for example, an example of that is amyloidosis, which Mondar Aras has really led a terrific group here with oncology and the heart failure team for the past few years. Mondar has also superhead another clinical program in collaboration with Emily Berksland in neuroendocrine tumors and carcinoid heart disease. And I know a number of you took care of a very sick patient last week in house who was a patient with carcinoid heart disease and was kind of waiting for surgery. I think these questions are interesting for us, both from a clinical standpoint, but also from scientific reasons. For example, one question I've been very sort of struggling to answer is, why would a heart suddenly divide and cause cancer in the heart? And if we could learn about the mutations that lead the heart tissue to suddenly divide in the form of a cardiac sarcoma, perhaps we can learn a lot about how heart cells divide in general. And so one of the efforts we have undergoing is trying to get tumors from around the country and really around the world to be able to look at genetic mutations that drive a heart to suddenly divide. This field has taken on other roles. We have known for many years that there can be common risk factors for heart disease and cancer, number one and number two cause of death. We know if patients smoke, they have a higher risk of developing lung cancer. And I think everybody knows if you smoke, you also have a much higher risk of developing heart disease. We are also kind of encountering this in the last 10 years, that classic cardiac risk factors like obesity, hyperlipidemia, and diabetes are actually important drivers of cancer. This is really an important concept. A few years ago, Cliff Eudes, who was a president of American Society of Clinical Oncology, called obesity, not cigarette smoking, as a number one preventable form of cancer. And if you think about it, if you can think about how mechanistically this comes about, you can do a lot in terms of better of public health in general. And this picture is taken on a totally different field with genetic predispositions to both cancer and heart disease. There are certainly clinical syndromes where you have inherited mutations from mom and dad that could drive both cancer and heart disease. But the most interesting form has been this thing called CHIP, clonal hematopoiesis of indeterminate potential. And this is a paper we wrote with my former boss, actually, at the Brigham, Peter Libby, which kind of depicts what happens. Here you have in CHIP mutations in blood cells, specifically stem cell, hematopoietic stem cells. These are usually epigenetic mutations that lead to clonal expansion of a subset of cells. Now, for many reasons, our hematology colleagues knew this by itself didn't mean anything. There is a small risk of developing cancer. And for that reason, because simply the clonal mutations and the clonal expansion didn't really mean much, this was called clonal hematopoiesis of indeterminate potential, because sure, there was a slight increased risk of developing hematological malignancies and perhaps other forms of cancer, but really this was a very small subset of patients. And about 5 years ago, really seminal work by Ben Ebert at Dana-Farber showed these patients with CHIP die much earlier, and the number one driver of events is actually cardiovascular disease. And this has actually been a really nice way to think about cardiac disease. I literally was talking to one of my colleagues, Pradeep Natarajan, who's a leader in this field at Mass General a few days ago, and he told me his most recent data indicate it's on par with diabetes as a number one risk that can drive cardiovascular events. And perhaps in line with that, I want to take this opportunity to introduce to Amy Lin, who some of you will encounter. She's going to be a new faculty member within our group. Amy is very talented. She had an MD PhD from University of Toronto, completed a Brigham residency, and then worked with Ben Ebert for the last 3 years. She's actually coming here to join a startup, 1016 Bio, that's going to be focused on CHIP and cardiovascular disease. But she's also going to use some time to have established a clinic in CHIP within our group. And so it's I want to also take this opportunity to introduce her to you. Now, again, you may say, well, there are all these common risk factors. There are a lot of people out there. And as cardio-oncologists, we tend to think of this, especially in the context of our cancer survivors. We have now in the US, 18 million Americans. That's 5% of the US population. That's cancer survivors. And so when you think about it, everybody knows that if you have had cancer, if you had breast cancer or prostate cancer, we should screen for recurrence of these cancers in patients, right? But the real truth is, in all of the population of cancer survivors, the number one preventable cause of death, or at least number one cause of death, still remains cardiac disease. And you can argue, well, because they beat their cancer, they may not have heart disease again. But if you actually buy into this idea that there are common risk factors driving this, you may have opportunities to actually treat these cardiac risk factors, not just to decrease the risk of cardiac events in these patients, but perhaps possibly to decrease the risk of cancer. And this idea, as you can imagine, has incredible public health implications for patients. So this is actually part of the guidelines that we put into the ESC. This is a simple ABCDE step that we developed initially at Vanderbilt, but I think it can apply to the many cancer survivors that we see in our clinic. Although I will be honest, the main reason this field has also exploded is due to explosion of new therapies in oncology, which can have adverse cardiovascular events. And because many of these treatments are fairly effective, and the cancer patients can actually live, we actually care about cardiovascular issues that come in with patients. Now, if I were to spend the next rest of this talk, and I can spend probably the next 5 hours talking about various cancer drugs that have various cardiovascular events. In fact, in the context of our clinic, we have to know about all of these. But I was going to give you a high-level overview of 3 of these that we encounter, in part to sort of convince you that what we're trying to do in our group really has relevance to a lot of other people within the cardiology group and at a larger medical center. So I'll just kind of go through this, and we can tell me what you think. So the idea that I was thinking about the time I started thinking about doing this and thinking about cardio-oncology is I had finished my cardiology fellowship at the Brigham. And just to get a taste of research, because truth be told, I'd done 1 year of research during medical school through a program called the Sarnoff, but really I didn't have a PhD. And so I tried giving research another try because it was sort of, I thought the 1 year was pretty interesting. And for reasons I won't get into, I find myself in a lab at neighboring Dana-Farber, which is a cancer center. This is a lab of Bill Kalin, which was studying kidney cancer. And although I was very focused on the transcription factor biology for my basic research, it was interesting because the lab was essentially a kidney cancer lab. And what was interesting is I had learned a few years earlier in 2004 that really kidney cancer was not a disease or a type of cancer for which we had many medical options. In fact, I remember a surgeon telling us, a urologist, about what kidney cancer is. And when I was in 2004 as a medicine resident, he would line up and ask us, what are the treatments for kidney cancer? And of course, we couldn't come up with one. And he would sort of laugh and say, aha, that's because kidney cancer is a surgical disease and you medicine people have nothing to provide for our patients. So that was at least in 2004, although I learned quickly by 2007, there had been an explosion of therapies that had come about for kidney cancer that were effective, and they were not by any means curable, but they were effective in light of the fact that nothing else existed. But it really came down to understanding the basic biology better. I think something we need to think about in cardiology. And so in this case, for example, it had been shown that you can have mutations in a tumor suppressor gene called VHL that degraded HIF, and HIF, being a master transcription factor, induces all these angiogenic factors, which for the first time explain why kidney cancer is so bloody as a tumor. In fact, most surgeons, urologists, want to take the whole kidney out rather than take part of the kidney out if you have a focal cancer. If you understand the biology, you can start thinking about developing drugs that target this pathway. At the time, the dogma was that you're never going to be able to target a transcription factor. And so much of the focus was on these downstream targets of HIF, which are either secreted or have receptors. And these came in the form of VEGF receptors, drugs like sunitinib and sorafenib, that by 2007, only 3 years later, had been approved. Now, what was interesting is we encountered, by this time, had started a small clinic at Dana-Farber, later at the Brigham, that we encountered basically new forms of heart disease that nobody had encountered before. We saw patients with hypertension, proteinuria, and cardiomyopathy that present after they get some of the VEGF inhibitors. And I spent much of the next few years trying to understand the biology in terms of developing ways to best treat and help diagnose and treat these patients. There's one side of this that's pretty interesting. As we sort of established this clinic with these drugs that target VEGF, we realized cardiomyopathy is only a small subset. In fact, most patients, right after they initiate drugs, they have both hypertension and proteinuria. At the time, I had this clinic with a nephrologist, Ben Humphreys, who was a sort of a mentor to me in many ways. He was a few years ahead of me, had already had his own lab. And so we realized we would see the same patients on the same afternoon. And I would go back to clinic and say, well, I saw Mr. Smith. And Ben says, oh, yeah, I saw Mr. Smith too. Turns out the same patients were seeing myself and Ben for both having hypertension and proteinuria. Now, this was really interesting. And the good news, I guess, here was we were both young enough at this point to remember from our medical school days that there was only one other condition where normally patients who have no hypertension and proteinuria can suddenly develop both. And we thought a lot about this, but it actually turns out the other place we see this is 3 to 5% of pregnancies where women can have something called preeclampsia, which is marked by hypertension and proteinuria. And as you know, pregnant women with preeclampsia are especially at risk of developing something else, which is much more dramatic and can be drastic in peripartum cardiomyopathy. Now, what's really interesting is our colleagues in several places, Zoltarani at Penn and Anand Karamanchi, who at the time was at the Beth Israel, he's a nephrologist, had figured out that there's actually one factor that drives much of the pathology that we see in pregnant women, and that's soluble FLT1, which it took us a few weeks to remember that that's just another name for soluble VEGF receptor 1. I have had actually the great chance to work with some of you, including Arturo, a few months ago or last month at least, on consult service. And he said he's interested in this new area called cardio-obstetrics, which we sort of struggle to define, I would say, exactly what it encounters, whether it includes congenital disease patients or not who go on to develop pregnancy. But obviously, one of the main things is this idea that you're focused on pregnant women and what effects they can have, cardiovascular issues can arise. These patients can have preeclampsia, they can have cardiomyopathy, and any woman who does have preeclampsia has increased risk of developing events later, even if they don't get pregnant. So it's actually a very interesting sort of theme to think about. Now, we've used the patients that we are seeing, and in collaboration with two colleagues, John Brown and Josh Beckman at Vanderbilt, actually got a couple of grants to really focus on these patients. Although we made the argument that if we focus and use our leverage our cardio-oncology program to study these patients, we can actually learn a lot about the bigger biology with respect to pregnant women and how they can have cardiovascular issues. So this is one example of a place where there are opportunities perhaps for us to think about. I'll give you one other example very quickly. So it turns out many B-cell malignancies have a gain-of-function mutation in a protein called Bruton tyrosine kinase. And so that has, of course, informed this idea that perhaps you can make a kinase inhibitor targeting this pathway, and that could be really be effective for many sort of B-cell malignancies. These include CLL, they include mantle cell lymphomas, they can include another subset of lymphomas, Waldenstrom macroglobulinemia. And this drug, Ibrutinib, has been a game changer. It's actually now and these are numbers from last year, the people who make Ibrutinib, actually the total revenue from Ibrutinib in 2021 amounted to $10 billion. And that's number 7 of list of drugs in terms of revenue generators, and includes the COVID vaccines at number 1 and number 3. And so this has been very interesting. These drugs have completely revolutionized how we treat B-cell malignancies, except for a small problem. As we quickly found out through the context of our clinic, these patients can have a higher risk of developing atrial arrhythmias. And this also, as we found out later, includes ventricular arrhythmias. Although there's not much heart failure, there are not other things that we see. And so one sort of, again, scientific question beyond how we can best take care of these patients and how we can potentially think about arrhythmias is to think about what the biology is. And so one obvious question that we had early on was whether this was an on-target effect, the Ibrutinib, is it because of BTK inhibition that we see arrhythmias, or the effects are on some other kinase. And we actually tried this. We had a very friendly competition with one of my friends, Dave Milan, who's pictured here, who was at Mass General. And I can tell you, in all honesty, Dave beat us to the punch in a pretty emphatically, and he figured out that the target here is actually CSK, not BTK. Now you can think about this at its face value, that there's just CSK, and there you can have some ideas about how atrial fibrillation occurs in this population. But if you think about it more broadly, if CSK has an important role for other forms of atrial fibrillation, it has significant relevance for all of our EP colleagues. Because as Greg and others can tell you, Zia and I think I see on the call, we really as cardiologists have very little idea of the mechanisms, signaling mechanisms for atrial fibrillation. This also affords us other opportunities. Obviously, with one drug making $10 billion, literally every other company wants to have a skin in the game. AstraZeneca has a drug called the Ibrutinib that appears to have less cardiotoxicity. In the collaboration with Jennifer Brown at Dana-Farber, we're now about to start a multi-center study where we actually put heart rhythm monitoring on all these patients and for the patients to undergo MRI. And the funding actually comes from Ibrutinib's competitor in acalabrutinib, folks, AstraZeneca, because the only difference between the drugs potentially is this difference in arrhythmias. And this has actually become a very important issue and part of patient care. I want to sort of switch gears for a minute and talk about something completely different. And I'll spend the next, let's see here, 15 minutes on this topic. I'm going to talk about a class of therapies called cancer immunotherapies, and specifically a class of therapies called immune checkpoint inhibitors. I'll tell you what they are in a minute, but just to sort of for everybody to remind everybody, with all due respect to everything we have done in cardiology, immune checkpoint inhibitors have been the single biggest advancement in all of medicine. Perhaps not surprisingly, the two people who identified this pathway, Jim Allison at MD Anderson and Tsuko Hanjo at Japan, won the Nobel Prize in 2018. These drugs, nobody thought they would work. These immune checkpoint inhibitors, they're thought to be sort of inhibiting the immune system. There's nothing selective about it. Yet they have been transformative in cancers like melanoma, for which there are no other treatments at the time. Now, 50% of patients, all cancer patients, are eligible for ICI treatment. And in the case of melanoma, they've really introduced survivorship as a new theme in oncology care. I'll be honest, not every melanoma patient sort of benefits from the drugs, but it is about 50%. But if you just want to remind everybody, 10 years ago, there were no treatment options for melanoma patients. And in fact, 0.5%, if that, was the survival rate for these patients. Now we're seeing long-term survival in patients at 50%. Again, one of the biggest questions in the field is who responds and who doesn't. But I think we are also beginning to see some poster childs for these drugs. Some of the older people in the audience may recognize this individual to be former President Jimmy Carter, who just turned 97. At the age of 90, he had metastatic melanoma that went to his liver and his brain. And after getting one of these drugs, a single agent PD-1 inhibitor, he's been completely cured of his cancer since 2017. Really a game changer in terms of how we can have treatment options for patients. I'll remind you again what these drugs do. Again, in the context of a T cell encountering an antigen-presenting cell or a tumor cell, it recognizes this other cell through the context of a T cell receptor, but importantly in the context of something called an MHC molecule that that expresses an antigen, a protein that's sort of foreign, if you will. Now, the truth is, this is not entirely sufficient to drive T cell activity. In fact, if we just have this encounter, the T cell undergoes energy and doesn't respond. You actually need co-stimulation molecules. And one of these names for these is CD28 and CD8086. That sort of act as co-stimulation molecules. So you need signal 1 and signal 2. But as soon as a T cell becomes active, now you have these other molecules that are inhibitory molecules, and they go by different names. CTLA-4 is one protein that's mostly in the lymph node. PD-1 is another one. And when a T cell becomes active, this CTLA-4 or PD-1 gets expressed, and they outcompete for the co-stimulation molecule. And this is the way we kind of teach the T cells not to become too active. It's a way that you can sort of think about keeping the system in check. Now, you can imagine if you're a tumor cell, and as Priscilla knows, if you're an HIV infected cell, you decide to sort of hijack this pathway, perhaps expressing a lot of PD-L1. And so now you, even though the T cell wants to kill the HIV infected cell or the tumor cell, it can't, because this host cell has really expressed these inhibitory molecules. So even though this encounter effects, they're sort of invisible, if you will, the cells to the T cells. And all these drugs really are checkpoint inhibitors. They're antibodies that bind the CTLA4 or PD-1. And again, there are multiple molecules in this pathway. And so the big thing here is they inhibit this pathway. The two T cells become active and they can go either fight the HIV infected cell or the tumor. And that's what these drugs, these immune checkpoint inhibitors are. Now, one thing that's changed over the last few years is we essentially combine these. If one drug works well, the oncologists just learned that they combine them. And in this context, around 2016, we saw a patient like this. This is a 65-year-old female with metastatic melanoma, much like Jimmy Carter, who had received ipilimumab, which is an anti-CTLA4 antibody, and nivolumab, an anti-PD-1 antibody. And a few days later, kind of came into the emergency room with chest pain and shortness of breath. And as every fellow knows, as soon as you walk into the ER, even if you didn't have chest pain, you get a troponin check. And in this case, sure enough, they had a troponin check, except it came back extremely abnormal, 24 or so, which is very abnormal. And what's also interesting are the EKG findings with this patient. This was the initial EKG, which some of you, I won't call on anybody, can see kind of the heart kind of becoming to undergo heart block. And this is the subsequent EKG where you have ventricular tachycardia. And sure enough, this patient died shortly after presenting. Now, if you pause for a minute, this patient could have died of anything, because many things can cause your troponin to go up and can cause for you to have arrhythmias. But really the autopsy in this case, the pathology, told us exactly what the story is. This is a normal heart, just as a reminder, and this is what this patient's heart looked like. So for those of you preparing for your boards, this is classic Dallas criteria for myocarditis, where you have immune infiltration, these little blue dots here. You have a lot of dead myocytes, that's the white space here. And then these blue cells, the immune cells, are next to the dead myocytes, which is a classic triad, the so-called Dallas criteria for myocarditis. So the patient, by all means, had myocarditis. I'm going to digress for a minute, because if you are a fellow, and this is in this case, I was a junior attending, sort of starting this whole program at Vanderbilt, this can be a pretty nice opportunity, because when I called around the so-called myocarditis experts out there, nobody had idea what this form of myocarditis was. And at the time, it was fortuitous because we had started the first fellowship in cardio-oncology. And one of the goals of our program has been to train the next leaders in this field. And these are some of the people who were training at Vanderbilt with me around 2018 to 2020. And they've some of these people have gone on to have very successful careers. Joe Ellie just became a full professor at Sorbonne University. And Walter Myers, who's gone on to Holland, just learned today he had a Nature paper accepted. So really kind of credit to them. But a lot of these fellows who trained with us went on to have successful programs literally around the country and around the world. And this allowed us to have a nice opportunity to effectively study a new clinical syndrome. So in this case, we were fortunate to establish an international ICI-Myocarditis registry. I was at Vanderbilt at the time, and I should mention I have UCSF here, partly because I'm now at UCSF. But even before I came here, Mandar and Alan were really big contributors to this with many of the cases that we have seen here. So fast forward to now, we have really defined a whole set of inflammatory heart disease processes that occur with checkpoint inhibitors. They include vasculitis, pericarditis. For some reason, even in the absence of inflammation, we see a lot of arrhythmias, although the most immediate concern are patients who get myocarditis. And as you know, one of the challenges of myocarditis is prompt diagnosis. So over the last few years, in a series of papers here, we've gone on to better understand what this clinical syndrome exactly is. We've collected close to 1,000 patients from around the world, and we're constantly going through to better understand the syndrome. We now know this is classic myocarditis, not just from the first example I showed you. This includes T cells and macrophages that infiltrate the heart. Obviously, when you have myocarditis, you can have arrhythmias or heart failure. And for some reason, this form of myocarditis is very arrhythmogenic, something that we're really sort of trying to study better. You can have patients who have other immune-related side effects, including myositis, which we can potentially explain, but also myasthenia gravis. Many of the patients with, especially the very severe cases, the events occur early after initial exposure to therapy. The median time from initial exposure to therapy is 25 to 30 days. And be it as these are antibodies, patients really see this after first or only second doses. As you know, antibodies, you give them only every 3 weeks or so. We have looked for a lot of risk factors that define this. Who really gets the syndrome? We've looked at cardiac risk factors. Are these patients who've had 3 stents placed a few years earlier? Or are there rheumatologic risk factors? Is it the 28-year-old or 30-year-old female with lupus that gets the syndrome? And we haven't actually gotten very far there in the context of this database that we have. Although we've realized that there's one main risk factor is where you combine the therapies, when you combine a CTLA-4 and PD-1, for example, and that's where it seems to be the recurrent risk factor. And of course, I just told you that's where the field is going. Our oncology colleagues, literally for every patient now, are thinking about combination therapy. Fortunately, the incidence is pretty low. It's only about 1%, although the mortality, as some of you have encountered these patients, can be pretty high, somewhere in the 40 to 50% range. We have thought a lot about how we can model these to better understand the syndrome. And this is really led work by Walter, Ellis, and Juan, who's now at UCSF, in terms of developing mouse models, either by giving the drugs or in this case, genetically depleting the targets of the proteins, in this case, CTLA and 4 PD-1. And there are some very interesting things that we see that is probably true also in our patients. Again, in this case, you're knocking out the genes. These mice start developing and dying very suddenly. We go on, I'll show you some data where these are in fact arrhythmogenic. But for some reason, it's mostly female mice that are affected. And this is something that we keep seeing perhaps in some of our patients as well. And this is very interesting because garden variety myocarditis is mostly males, and I'll come back to that momentarily. Again, these mice die of one reason and one reason only, and that's myocarditis. This is for some of my electrophysiology colleagues. This is actually a mouse electrophysiology study, and this is just to convince you that this is in fact the mice have arrhythmias, much like we see with patients, heart block, but also arrhythmias, and that's how the mice die very suddenly. Now, one little bit of basic research. It's very easy to look at a histology picture like this, and this is for all my clinician colleagues, even potentially do some immunohistochemistry that looks at the population of these little blue dots. What are these? Are these T cells? Are they macrophages? What is really infiltrating the heart? And so you can do this in many sort of traditional techniques, although one thing that's been very interesting, and this is what we've done, this is unpublished work now for some of the mice patients that we have, you can use a technique called single cell RNA sequencing, where you divide up the different cells. In this case, we focus only on immune cell populations. And based on the genes that are expressed, can then think about what these could be. So for example, you have no idea because you mix up all the cells, what the cells are. But later when you look at the genetics, you see pockets of, for example, naive T cells or activated T cells that you see here in these mice. And this is a technique that really revolutionizing our understanding of cardiac disease, although for reasons I'll discuss momentarily, we've decided to focus on inflammatory heart disease. And so here you can quickly not only understand what the cells are in fact, what subset of T cells there are. They're, for example, mostly activated, but some of the specific genes that are either overexpressed or underexpressed when you compare two populations. In this case, we've taken myocarditis affected mice versus complete control mice. And again, I won't show you these data, but we've done the same with the patients. Again, for this specific sort of approach, we're only focusing on the immune cells, although if anybody's picked up a copy of Nature in the last couple of months, they know this. You can do this for the entire cell, although for technical reasons, you do something called single nuclear extraction before you do the RNA extraction. I bring this up because I want people, the clinicians in the room, to know much of our approach to inflammatory heart disease and heart disease is really changed based on this and other techniques. And this is sort of what we've taken to sort of heart here. And so one quick story I'm going to tell you, because it's only one slide, is one thing we've realized with these T cells that become activated is that they're also clonal. They're not only activated in checkpoint myocarditis, but they're also clonal. They express the same T cell receptor, which defines clonality of T cells. And one sort of next question has been what the antigen is. Is there one particular antigen that drives the ship? And in a story that we'll have later in a couple of months, we've been able to show that the antigen is actually one of the myosin heavy chains that seems to drive the ship. And as you can imagine, this has significant implications for patients and who may be at risk of developing this and other forms of myocarditis. So I told you we were able to get these mouse models and these human samples from around the world. And one thing you can do as an investigator is hoard onto things and not share with anybody. We have actually decided to do the opposite, sharing these resources with anybody who wants to work and take these on. And so we've been very fortunate to work with some really talented people, really people much smarter than me. And for example, with Justin Balco and Doug Johnson, we started 2 R01s trying to understand the immunogenic and antigenic drivers of myocarditis with checkpoint inhibitors. While I was still at Vanderbilt, I got a call from a company called CellSite, which happens to be at China Basin, and Young Ho Seo, who some of you know is a radiologist, PhD. And we're just fortunate to get an R01, which looks at novel PET tracers for looking at diagnosing myocarditis. Again, I think this has significant implications for how we think about diagnosing myocarditis. As many of you know, it's not so simple at the end of the day. We have a story coming out. This is Juan Chin, and in collaboration with colleagues at MD Anderson, about why there are sex differences in this form. And I won't bore you with, I won't go into the details too much, but suffice to say that there are cardiac specific factors that are expressed that are modulated by estrogen that tell the immune cells not to attack the heart. And so we're excited about this, and especially the fact that these factors are modulated by estrogen, something that we feel has significant relevance for all forms of myocarditis, including all these things you hear in the news about vaccine-associated myocarditis. As you know, the opposite is true in other forms of myocarditis where mostly males are affected. With Corey Levine at WashU, we've been focused on other forms of macrophages and how the macrophages play a critical role in this process. And with Chris Rosiek and Tony Latai, we're looking at mechanisms of immunogenic cell death. Now, some of you may be rolling your eyes and saying, well, what does this have any relevance for our patients? And I would argue that if you actually take a step back and think about the underlying mechanisms, you can think about therapeutic options. Again, I told you most of these patients, 40 to 50% die from myocarditis when they do encounter. And so one obvious question, knowing that we had showed that CTLA-4 signal is critical for the development of myocarditis, is whether we can reverse this somehow. We can give a CTLA-4 agonist, if you will, that drives this. And so the mice models proved to be very useful. There is a drug that actually works as a CTLA-4 IG or CTLA-4 agonist. And in both the pharmacological mice models, but also importantly, the genetic mouse models, you can see that we can attenuate the myocarditis. And we've taken on to patients. This is Joel E. Solom that I showed this picture earlier. He'd literally walked over to my lab went to Paris and established arguably one of the best programs in the world now. And he encountered one of these patients and gave them abatacept. And in this case report in New England Journal of Medicine, he shows that it can, in fact, be effective for treating these patients. With Joe now, we have about 50 patients that have been successfully treated. We're excited about these data, about how this can afford an opportunity for treatment for our patients. And this is something we're pursuing further. This is Alan Beck, and he wrote a terrific circulation review a few years ago, really reminding us how these immune checkpoints really represent a subset of immunotherapies that exist. There are some things called CAR T cells where you can re-engineer a T cell such that it does encounter a specific antigen that's expressed on a type of tumor, and these have also been revolutionary. They work very different, mechanistically very different than the immune checkpoint inhibitors. And there are other things. I was talking to Sap Haldar, who much of Amgen is focused on these other molecules called bispecific T-cell engagers, which work in a whole different pathway. And as Alan reminds us in this very nice review, there are multiple immune-mediated cardiac effects that we see in patients with different forms of cancer immunotherapies, one of which is something called cytokine release syndrome, which can happen in the context of CAR T. And this is at least just to show us that perhaps some of the issues we see with CAR T can be reminiscent of another syndrome we have seen, cardiovascular issues of another syndrome, which is SARS-CoV-2. And this is just to tell you again why we're so focused in this area for our program, because it can potentially teach us about other forms of cardiac disease that have nothing to do with cancer patients. And just to remind you, Arun's PhD boss, John Epstein at Penn, had this phenomenal paper a couple of years ago about how you can potentially even re-engineer T cells in terms of treating cardiac disease. This is merely a proof of concept, but this is another area I think we should be thinking about. These could not only be important for the cancer patients, but thinking about and getting a playbook from the oncology colleagues can potentially may let us to think about new therapeutic options for our patients. I want to leave you with one last slide, and I certainly want to make sure we have time for questions. I told you we're in our section, we're thinking about more broadly about cardio-oncology, or even something called perhaps cardio-immunology, because much of what we have learned for the past few years about just other forms of myocarditis, for example, other forms of inflammatory heart disease, for example, myocarditis, is probably just things we have learned from previous generation. And in fact, as somebody who's now presumably a myocarditis expert, I can tell you a lot of this is arbitrary. So for example, one of the things we learn in our textbooks is you take a piece of tissue from a patient with myocarditis and you have a pathologist take a look at it. And depending on perhaps on how much coffee that pathologist had that morning, they may or may encounter and tell you they see a giant cell or they see an eosinophil. And based on that, we make these arbitrary classifications about myocarditis. And so one of the goals of our program, and Amir Munir is superheading this, is can we use some of the new technologies that we have developed, these single cell expression things, other form of platforms, including the T cell sequencing that I mentioned, multiplex immunofluorescence, to better characterize the immune cells rather than some pathologist taking a look at it and thinking they see a giant cell or thinking they see some red in the cytoplasm to call it eosinophilic myocarditis. And I think this sort of concept goes beyond just myocarditis in general and can perhaps translate to things like cardiac transplant rejection, where we readily get human tissue from patients. Mondar tells me this because he does this. He gets every one of his patients that undergoes a transplant gets a biopsy. Can we leverage this to understand the clonal hematopoiesis in general? Can we leverage this to understanding perhaps atherosclerotic disease? And this is sort of an idea that we have for this next chapter for our program in terms of really thinking more broadly beyond cancer patients, and for at least practical reasons, really focusing on inflammatory heart disease in general. So I'm going to stop there. Again, I want to sort of acknowledge many, many people in our program. I acknowledge some of our many collaborators along the way, but I'm happy to answer any questions and sort of go from there. And I think I mentioned this earlier. I think this program has really come together because of these three people here, Eileen, Amanda, and Carrie, who joined us, Carrie in this case, just a few weeks ago, who's really the pillars for our program, who make sure we provide optimal patient care. Thank you, and I'm happy to take any questions.
Great. Thanks so much, Dr. Moslehi. That was a fantastic lecture. It gave us a great overview of the field of our cardio-oncology and also shared with us about your trajectory and how it was that you came to be a leader in the field. So we have time for a couple questions. And so if anyone has questions, you can either raise your hand or feel free to leave your question in the chat box. I can go ahead and ask maybe one of my questions. I thought it was really interesting when you brought up the conversation about reversal agents for immune checkpoint inhibitors and myocarditis. And I was thinking, it seems like a lot of it is preclinical, or you mentioned, a few cases and instances where things like abatacept were used. Are we moving towards clinical trials for those types of agents? Do those exist? And if not, from an investigator's perspective, what are challenges in running that kind of a clinical trial?
Yeah, so there are actually two clinical trials happening as we speak. One is actually run by Joe at France, where he's trying to figure out the optimal dose of abatacept. Our Boston colleagues have further jumped on this, as they do typically in Boston. I can say this because I came from the program, where they're basically trying to do a trial, but they don't actually quite know the dose. One other thing we've realized is actually the time frame for abatacept can be several, take some time for abatacept to work. And we've realized, I didn't have time to show you, inhibiting another pathway that's complementary in interferon and JAK signaling. And there's a drug called ruxolitinib that does this, gives you optimal response. And so now we have, I should say, Joe Ellie has these 50 patients that have been successfully treated with the combination therapy. So one, we're going to have to figure out the dose. I think some of the trials happening now is sort of premature, specifically the one trial I mentioned. But I think the bigger one will be sort of combination therapy and really figuring out the right dose of abatacept that we should use. Happy to talk about more details on that, but I thought that was a sort of an overall.
Great, that's exciting. Anyone else with other questions, feel free to just unmute yourself and speak, or again, just put it in the chat box. Are there reversal agents that we're thinking of for VEGF inhibitors?
Yeah, so the one question that often comes up is it on target? We think it's actually on target for a variety of reasons that I showed you. Although I think the other truth is, and I didn't get a chance to get into details, the cardiomyopathy is many times reversible, as is also the case with peripartum cardiomyopathy. As people know, some of the patients do very poorly, but many of the patients with peripartum cardiomyopathy have reversibility once you stop the insulting agent. So either it's the pregnancy or the drugs themselves. We're interested in better understanding the hypertension because this is a common reason we encounter these patients. And the question there is really, what's the best choice of a drug to use? And we really don't know. We use ACE inhibitors as the first pass because if you think about the concomitant proteinuria, in our clinic, we use, and Alan has been sort of at the forefront of this, I should mention, calcium channel blockers that as a second agent. And then it's sort of anybody's guess. Many patients, of course, as you know, already have bad hypertension. And really, especially with the newer agents, the blood pressures can go up significantly. And so I think that's one of the areas I think that is sort of interesting to think about. So it's not so much about a specific drug that can do this, but rather what choice of antihypertensive we could use.
Got it. So treating the sequelae of the VEGF inhibitors that they're getting rather than trying to just reverse it. Okay, any other questions? All right, well, if no one has other questions, thank you again, Dr. Moslehi, for a fantastic talk.
Really a pleasure to be here and work with everybody. Thanks so much.
Yeah, a recording should be available on our division's YouTube page shortly. And I hope to see you all next week. We're going to hear from Dr. Matt Durstenfeld about the impact of COVID on the cardiovascular system. Thanks, everyone.